Hello, everyone. Welcome to this webinar hosted by the California Telehealth Policy Coalition. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy, the convener for the California Telehealth Policy Coalition. Today's topic is on telehealth and value-based care. Bit of information and background on the California Telehealth Policy Coalition. It was founded with 5 organizations originally back in 2010 to look at telehealth policy in the state of California. We've now grown to over 151 statewide and national members who are interested in advancing telehealth policy in the state. If you are interested in joining the California, please reach out to CCHP staff and we'll make sure to provide you with information. We'd like to thank today's sponsor for this webinar, the California Healthcare Foundation and the Center for Connected Health Policy. Purpose and key objectives for today's webinar is to provide an overview on how telehealth and value-based care can improve patient access to care, to discuss different stakeholders' perspectives on value-based care and the impact on patients. There will be a panel discussion on the various value-based care payment models, as well as the role of public policy and related challenges and opportunities. And we hope to answer key questions around value-based care and how telehealth interacts with it and on proposals moving forward. We are fortunate today to be joined by a great panel of speakers, as well as our very well-informed moderator, Robbie Franceschini from Blue Path Health. And our speakers will include Chris Crowley from West Health, Cindy Keltner from the California Primary Care Association, and Audrey Young from Blue Shield of California. So I will now turn it over to your moderator for today, Robbie.
Thanks, May, and great to be here with everyone today. As May mentioned, I'm Robbie Franceschini. I work with Blue Path Health and I'm the policy director there, and also have the great fortune of helping to manage the Telehealth Policy Coalition with May and Amy and the CCHP team. As our education committee was looking this year to put together our programming for our webinars, I think a lot of different options have risen to the fore in terms of policy developments and industry developments in healthcare and how telehealth relates to them. And I think one of them that's come up, at past annual meetings and other webinars is around value-based care, value-based payment models, and really how telehealth fits into them. If we go to the next slide, just to provide a little bit of definition, value-based care really looks to reimburse providers for really the total cost of care, and really emphasizes quality and outcomes over a fee-for-service model or volume. In terms of some of the early outcomes we've seen, it does seem like a shared savings model where providers are responsible both for upside and downside risk seem to lead to lower costs. But I think as we have kind of moved forward in this work, it does appear we're kind of early on a value-based care or value-based payment journey. Over the past decade, I think with a lot of federal leadership and support, a lot of models have been tested, and I think you'll hear about some of that today, with varying degrees of success or outcomes. I think as the Biden administration and the Centers for Medicare and Medicaid Services have scoped it out, they're anticipating that all Medicare beneficiaries and most Medicaid beneficiaries will be in some sort of a value-based payment arrangement by the year 2030. And currently today, about 50% of Medicare Advantage and traditional Medicare beneficiaries are in some sort of value-based care arrangement. And in the commercial Medicaid context, they estimate it's about 25% today. And really, value-based care and value-based payment, I think, really kind of span the continuum from, maybe a fee-for-service model with some quality metrics and payment tied to those, all the way to a more population-based model, where there is kind of full risk for a patient population. I think moving to the next slide, just to highlight on here those figures I just mentioned that CMMI and the HCP Learning and Action Network have pointed out are on here as well. And just moving to the next slide too, In terms of thinking about telehealth's role in value-based purchasing, I think to many people, it seems like telehealth can potentially be a great fit within these various payment arrangements. There is some evidence that suggests that value-based payment arrangements, those providers in them tend to use telehealth at higher rates. And that really could be for several reasons. One is thinking about how potentially the use of telehealth can lead to lower costs, which is a key tenet of value-based payment arrangements in terms of thinking about lowering costs using modalities that can meet the patient where they're at in a timely manner, in a manner that works for them. And I think similarly, there also isn't the need to, analyze multiple payers' fee schedules potentially too, and the modifiers that need to be attached and what's covered and what's not. I think as we've been on this telehealth journey throughout the COVID-19 pandemic, we at the coalition have been tracking, both public and private payers' policies, and they're often all over the map in terms of what's covered and what codes are to be used and how to bill. And it can be really complex and complicated for providers to be able to keep up with those advancements. Similarly and historically, even before the pandemic, there have been waivers that have allowed flexibility for providers in various, alternative payment arrangements to use telehealth. And I think a good example are the next gen accountable care organizations where, CMS waived a lot of the geographic barriers to using telehealth, even prior to the public health emergency. I think just another point too is, really the value-based payment and telehealth, both separately and importantly together, can advance health equity. Health equity has been something that the Telehealth Policy Coalition has been really focused on as, a driving value and policy priority over the last few years. And I think in a lot of our work, it's come through in terms of showing how, providing access to telehealth really can increase access to care, especially for a lot of our most underserved or marginalized communities. I think similarly, a lot of leaders in the value-based payment movement, including, leaders at the Center for Medicare and Medicaid Innovation, have also placed equity within their, strategic refresh and looking to equity as a value that should be embedded in payment models. So thinking about how we can measure quality and outcomes that can meet, the communities that we need to serve most. So without further ado, I'd love to introduce our speakers for today. And I'll start just by introducing them in their brief bios before we dive into discussion. Honored to be joined today by Chris Crowley. Chris is a systems engineer and quantitative analyst with a career dedicated to public health, safety, and well-being. His research interests include healthcare, finance, population health, and community-based care, as well as the development and navigation of successful aging throughout the continuum of care. At West Health Institute, Dr. Crowley has had the privilege of developing collaborative learning networks, working side by side with providers that look to eschew traditional volume-based payment incentives in favor of opportunities to embrace financial risk. Dr. Crowley received a PhD in electrical engineering from McGill University and a certificate in quantitative finance from Fitch Learning. We're also joined by Cindy Keltner. Cindy joined the California Primary Care Association in 2015 to lead the implementation of CPCA's comprehensive value-based care training and technical assistance program. She's also responsible for quality assurance, data and analytics, social determinants of health, trauma-informed care, outreach and enrollment, and behavioral health and care integration at CPCA too. Most recently, she also served as the executive director of the Healthcare Quality Institute, where she was a project lead for the Robert Wood Johnson Foundation's Aligning Forces for Quality program. Cindy has a BA in Health and Safety Studies from California State University, Sacramento, and an MPA from the University of San Francisco. And we're also joined today by Audrey Young. Audrey is the Senior Manager for Virtual Care and Innovation and Implementation at Blue Shield of California. Since joining in 2017, she's focused on defining the virtual care strategic roadmap and aligning that intent with the organization's mission of being a health plan that's worthy of her family and friends. And before that, she developed and implemented business and ambulatory strategic projects for one of the largest health systems in Northern California. Audrey holds a master's degree in healthcare administration from the University of Southern California and a bachelor's degree in government from St. Lawrence University. So I think to kick off our discussion today, I'd love to turn to each of our panelists really to, I think, briefly go over your role in a little more depth, as well as your organization's approach to value-based care and telehealth and how they're important to your work. So Chris, I'll turn to you first to lead us off.
Great, thank you, Robbie. And of course, thanks to the coalition for this important work. As far as the West Health organization, West Health is actually comprised of 3 distinct entities: the Gary Mary West Foundation, the West Health Policy Center in Washington, D.C., and the West Health Institute, which is a nonprofit research organization located here in San Diego. Together, all 3 organizations are dedicated to lowering the cost of healthcare, and specifically by enabling seniors to access high-quality health and supportive services, with a big emphasis on dignity, quality of life, and independence. So it's basically a 2-part mission focused both on cost and on successful aging. As far as my role at West Health is directed towards research involving re-engineering or retooling healthcare delivery. I'm specifically part of a team focused on dealing with unplanned acute care. So things like emergency department visits and hospitalizations are important to this team. For older, frail, medically complex, or advanced illness patients, these acute episodes are very costly. They're costly in financial terms, of course, but they are also a real hit against our mission of successful aging. We really want to disrupt that revolving door of chronic disease management that repeatedly cycles vulnerable folks in and out of the hospital. So as far as our work, we partner with provider organizations that operate under value-based payment models, involving various degrees of financial risk, but ultimately all of them tie to this total cost of care proposition that Robbie mentioned earlier. Historically, we've worked on Medicare value-based payment demonstrations, but more recently, we've kind of added multi-payer and are looking to include Medicaid value-based payment models. So we're basically tracking that CMMI trajectory that, again, Robbie mentioned earlier. So number one, value-based care is important to our work because it provides the financial incentives to kind of encourage that re-engineering of care delivery, but especially for those unplanned acute events for medically and socially complex older adults. And number two, telehealth is important to our work because it provides the means for engaging those vulnerable populations, and it specifically provides at least opportunities to catch chronic disease exacerbations before they really progress in intensity or severity, or, in complex patients, these things typically cascade and you get a lot of interactions of different risk factors. So that's really, telehealth figures very prominently in our embrace of value-based care.
Excellent. Well, thank you for joining us today, Chris, and for your work.
Thank you.
Cindy, I'd love to turn to you next.
Hi, everyone. Thanks, Robbie. So my name is Cindy Keltner. I'm the Director of Care Transformation at CPCA. I've been at the organization for almost 7 years. And as Robbie noted, I came to the organization really to work on our alternative payment model and value-based care work. Within my department, you heard we cover a lot of territory, but basically anything that our members are looking for assistance with, either technical assistance or training, anything that's forward-looking is what falls into our plate. We have several departments at our organization, and we do a lot of different work with our members. So we do a lot of advocacy. Telehealth is something that we, in March of 2020, started doing a lot of advocacy for, and still continue to do that because our members like that flexibility, and our patients, enjoy being able to, have the care when they need it where they're at instead of having to go into the clinic. So anything futuristic, telehealth, value-based care, a lot of the ACEs and trauma-informed care work that began a couple of years ago in the state falls into our domain. And we have a data team that does data analysis for our department, but also across the organization for different departments. So the alternative payment model is really very important to us, and value-based care in that aspect, because it's really the future, right? I mean, it's what patients want. It did not escape us that when the pandemic struck, if we had been able to get the state and CMS to agree to the alternative payment model we proposed in 2015, that our members would not be in some of the financial issues that they were, because their care would have been more value-based versus volume-based. So it's an important aspect. It's important to our members. And we see telehealth as a key component to being successful in an alternative payment model, being able to deliver the right care through the right modality, at the right time for patients, when they need it. We don't have a lot of data yet around the success of it, obviously, because we've only been doing it for a couple of years and data takes time to catch up, but we have a lot of great anecdotal stories, especially farm workers in the Central Valley being able to, use their phones, walk out of the field, sit in their car, do a visit with their physician. They didn't have to drive an hour to the doctor. They didn't have to wait for the visit and then drive an hour back to work. In a half hour, they were done and able to get back to work. And if you're a farm worker, you're getting paid hourly and maybe you don't have sick time. And so, it really has been beneficial from a lot of aspects, for a lot of aspects. And one of the other things that we see as sort of key to value-based care is social needs. And obviously, one of the things in California when we first started collecting social needs data, was that transportation was a huge issue for a lot of our patients. Not having a dependable car, having to rely on family and friends to take them places, or public transportation. So, telehealth improves the quality of care, but it also improves access to care. So patients are able to get the care when they need it versus postponing it because maybe they don't have dependable transportation, or their family can't take time off from work to take them. So it really improves a lot of different things and is much more patient-centered and patient-focused, which is what our members want to provide to our patients. So I'll stop there, and because I know we have more questions to come. So.
Excellent. Thank you, Cindy. And last but not least, Audrey, I'll turn it over to you.
Great. Thanks, Robbie. Hello, everyone. My name is Audrey Young, and I'm the Senior Manager for Virtual Care Innovations at Blue Shield of California. A few headlines about Blue Shield for those who don't know or who need sort of orientation as to sort of why we're sitting on this panel. Blue Shield of California is a tax-paying nonprofit independent member of the Blue Shield Association with over 4.5 million members throughout the state of California. We provide health, dental, vision, Medicaid, and Medicare health service plans in California, and have contributed more than $192 million to the Blue Shield of California Foundation in the last 5 years towards advancing health equity, building up our youth, and advocating against gender-based violence, just to name a few programs that are sort of near and dear to our heart. So my team within this larger context of Blue Shield of California, my team, the Virtual Care Innovations team, is primarily focused on advocating for and creating opportunities for equitable care that includes the use of telehealth modalities, because we really believe that virtual care is care, and it's not a separate concept that needs to be designed outside of the larger ecosystem of healthcare operations. Rather, it should be another avenue by which members and patients can access care when they choose to. So my group experiments and operationalizes programs that are engineered from the lens of improving the patient experience and improving quality outcomes. We work within the larger context of Blue Shield of California and with our provider partners to present opportunities for members to access care quickly while paying close attention to the value of care coordination. And we believe that value-based payments and the opportunities that are allotted to patients through telehealth is an important concept that aligns with our organization's mission of creating a healthcare system worthy of our family and friends and that is sustainably affordable. So thanks for having me, and I look forward to our panel discussion.
Thank you, Audrey. And I think you'll find you're amongst like-minded people and believing that virtual care is care here. So thanks for joining today. And I think we can kind of dive into discussion with all of our panelists at this point. I'd love to touch on something that Cindy that you mentioned earlier around why health centers would want to pursue an APM. And you touched on some of the financial issues that health centers and I think a lot of physician practices have encountered during the pandemic, and some of the other pros as well. But are there any more pros and cons of transitioning to an alternative payment model? And why FQHCs and rural health centers might want to or maybe be hesitant to move towards such a kind of payment arrangement?
Yeah, thanks for that question, Robbie. I think I'm probably not the one to ask about cons because I'm really pro APM, but I'll do my best to try to cover both aspects. So when talking with members who have expressed interest in an alternative payment model, there's a couple of things that bubble up to the top in most discussions with them. So one is better cash flow. So in the proposed alternative payment model that we're working on with the state right currently, it's a per member per month payment. So the clinics who are participating will get a monthly payment. First of every month, they'll get paid that per member per month for every patient that is assigned to them. So they will know. So it makes it easier to budget cash flow, to do planning for resources, because you know what you're going to be, basically you know what you're going to be getting every month. It may vary a little if new patients are assigned or go someplace else, but it is a much better payment process than what they're currently getting with the PPS process. So that is one thing. I think the other thing that is attractive to the clinics is the increased flexibility that they have with an APM. And because what happens is right now they're currently constrained about billable providers. So only certain providers can be billed for a visit. So if you don't have a billable provider doing that visit, then you're not able to bill for that. So without having that constraint, they can utilize other modalities of care. They can use other types of providers, so that they're doing the right care for the right patient with the right provider and not having to worry about, can I bill for this or not? If they need to see a health educator versus, a PC or, someone like that, then they can do that. If the health education is what they need, then they don't have to worry about that. So the flexibility of billable providers, and also the flexibility of the different modalities. In the APM, there will be a tool like an alternative touches. Telehealth is one of those alternative touches. Group visits is another type of alternative touch. So they will be able to do those alternative touches to provide patients with the care that they want. And that is why telehealth and value-based care really overlap for us, because it will be a key component of members doing that work. I think the other thing that not just our clinics, but other providers, other organizations in the state and the country are feeling right now is a workforce shortage. And so not being constrained by billable providers, you have the ability to fully use your workforce, to use your workforce at the top of their license. So it again helps provide access to care for patients. I think the one thing that scares most of our members is that change is hard, and PPS, it's been around for years and years and years, right? So there's a certain level of comfort there. They know when they do a visit what they're going to be able to bill. And so I think that there's some concern that, they might lose money or not be able to, make the same amount of money that they have been. But on the flip side of that, there are federal regulations that stop that. The federal regulations require that clinics get make at least as much in an alternative payment model as they would through a PPS. But that, again, is different and scary. And so I think that's the major sort of concern. And that and the fact that, they're getting a per member per month fee for everyone assigned to them, but not everyone that's assigned to them actually, they cannot always find everyone that's assigned to them. So, how are we going to deal with those patients? They lovingly call them ghost patients because they're assigned to them, but their phone number doesn't work, their address comes back, they have no way really to connect with them. So that is also another concern. So I think the good outweighs the concerns, but it's still out there. And I think the other thing that is to our advantage is that with CalAIM, the state's new program, there's a lot of overlap. So both programs focus on integrated care, both focus on value and outcomes, both are data focused, and both use population health management as sort of key concepts for them. So participating in the APM, using telehealth also helps improve their success in DHCS's CalAIM program. So I'll stop there.
Thank you. And I think it's really great for us to remember the whole context when it comes to value-based payment and the flexibilities it allows and really the kind of breadth of services it can capture, including health-related social needs and CalAIM. And I think that always has stood out to me as one of the benefits of moving to value-based payment as well. Chris, if you could maybe tell us a little bit more about West Health's work in value-based care and a little more about some of the focus of your work and the collaboratives that you plug into as well.
Sure. So as I indicated before, the foundation of our research is our partnership with provider organizations. We specifically form small collaboratives with providers who have already chosen to participate in Medicare value-based payment programs. The focus of this body of work is to treat value-based care redesign and telehealth in particular as a process improvement endeavor. So we actually partner with the Institute for Healthcare Improvement, or the IHI. They have, as many are probably familiar, they have a model for improvement, which very briefly is a structured approach involving a set of aims, measures-based tests of change, and Plan, Do, Study, Act, or PDSA cycles. So a change might consist of, for example, developing options for on-demand telehealth encounters as alternatives to an emergency room or urgent care visit. But in parallel with testing the operational challenges, because we're so focused on value-based care, is we also apply the model for improvement from the IHI to the financial processes too, in terms of substituting out costs for services that are averted, adding costs for replacement services. Of course, the overall expenditures need to be lower and the care equal or better in quality. But exactly as Cindy alluded, we found that a really important consideration is not only whether or not you can lower net cost, but kind of dealing with cash flow. Provider organizations work at notoriously thin margins. And even if they save money, they need to generally do so with services that are immediately reimbursable. If not, they need to be somehow recouped, either through other revenue sources or maybe shared savings later. But if it's shared savings, how do we know that those shared savings will even be available, say, 18 months down the road? So it's really important, those points that Cindy brought up on state APMs and cash flow considerations. When it comes to telehealth itself at a federal level, telehealth is reimbursable. It was reimbursable in the Next Gen ACO, as Robbie mentioned. And when we say reimbursable, it's always reimbursable, but with a lot of restrictions on origination sites and geographic limitations. So both in the Next Gen ACO and in the pandemic waivers, those particular limitations have been removed. But one of the challenges is for unplanned acute events, these alternatives to avoid hospitalizations, is the beneficiary or caregiver might be in a state of distress. And we found a lot of the organizations really want to have assisted telehealth. That means somebody, maybe it's a paramedic working outside of the scope of EMS services, maybe it's a medical assistant, but they need help sometimes, not just managing the communications, but also potentially helping to get some vitals or administer, say, some nebulized medicines, for example. So in the case of these assistants, those are not necessarily part of reimbursable service. And that again gets to that point about how do you work on the cash flow and revenue cycle management in order to realize these opportunities. So again, that just illustrates kind of this idea that in applying the model for improvement and treating value-based care as an improvement or process improvement endeavor, that we really have to focus not just on the care delivery processes, but also on the financial processes. And we're looking forward to kind of considering that, considering newer options as they become available, both at the federal level and of course here in California with CalAIM and some of the managed care plans. But that's a very important consideration in applying that model for improvement.
Excellent. And you know, I think with that, Audrey, you know, what as a health plan, as a payer, you know, what is Blue Shield's role in this work and in this transition to value-based care in California, maybe both at the, you know, industry and also at the operations level as well?
Yeah, that's a great question. So we've been involved in various collaboratives discussing sort of the benefits of value-based care for both patients, payers, and providers. And really the reason why we're doing that is because at our core, one of the main sort of focus points for us and areas for us is that we want to strengthen the primary care practice, whether that practice is in person or virtual. And so we believe that the primary care practice is the foundation of healthcare and of the healthcare system. And through value-based payment arrangements, we anticipate that we'll see an improvement in both the patient and the provider experience as the use of telehealth fluctuates and comprehensive primary care services are delivered via telehealth. So we want to encourage the use of telehealth as a main delivery mechanism when appropriate, while also making revenue predictable for our provider partners and producing better health outcomes. So that's the reason why we're doing it. Now going into the implementation, following the recommendation for the National Academy of Sciences, Engineering, and Medicine, and in an effort to support our members and providers, under our fully insured PPO line of business, we began piloting a hybrid pay-for-value-based payment model that reimburses providers and health systems through a mixture of traditional fee-for-service and PMPM per member per month payments. Under this model, providers will be paid a rate-adjusted PMPM for delivering primary care services, and adjustments will factor in expected utilization differences based on age, gender, and health conditions. And in addition to this predictable base, which is really important for us to make sure that we provide an opportunity for our clinical providers to be able to not have a concern about the revenue, as we sort of mentioned, as Chris and Cindy mentioned earlier. But we also also have a separate pay for value PMPM payment for each attributed PPO member that helps to further support the broad range of care coordination activities, as well as outreach to patients and families, coordinating with specialists and labs, medication reconciliation and review, as well as performance incentives that allows for practices to earn additional revenue based off of population outcomes. And it allows for fee-for-service payments on activities that we want to continue to promote, things like colorectal cancer screening, mammograms, et cetera. So we theorize that this new model and the predictable cash flow will allow providers to return to practicing medicine the way that they set out to at the outset of their careers, as well as help with the telehealth assistance programs that Chris had mentioned earlier, providing deeper engagement with patients both in and out of the office. So we're experimenting with pilots right now. Early data is showing us that we're reducing the total cost of care for specific groups of folks while maintaining the flexibility for different modalities.
Excellent. And, I think, we've kind of laid the foundation around why practices might want to move to value-based care, and kind of telehealth's role in it a bit. But maybe Chris, could you elaborate a little more around telehealth and maybe why it's well suited for value-based care? I know we've touched on, total cost of care, but, is there any more maybe you can share around, degree of risk, and maybe its correlation with telehealth use, or specific, instances where telehealth might play a big role in taking on more risk?
Yes, sure. So again, a lot of the work we've done so far is at the federal level with partners that are participating in Medicare payment model demonstrations. But the principle is certainly manifest there. Generally, the more financial risk in that payment model, the more the provider that assumes that risk should be empowered to do more and to have more flexibility and operate with fewer restrictions. So again, if you're responsible for all or part of the total cost of care, including responsible for downside losses, then if you choose unwisely to overuse a service like telehealth, for example, then you'll basically pay for it in the end. Generally, when restrictions on use of any type of care delivery are reduced, there's a lot of concern about overutilization, but within the scope of Medicare payment demonstrations, and again, especially with the more aggressive downside risk ones, those incentives to overuse a service are reduced or absent, because you'll basically pay for it if you overuse those. So it's kind of a quid pro quo, I think, both in the federal and state concept, that you get more empowerment and fewer restrictions in exchange for more risk. As we discussed a little bit earlier, the next generation ACO at the time was one of the most aggressive, and that's the one that began to explore relief from the origination site and geographic restrictions. So I think that an important point is that in that Medicare level, new codes weren't really developed. It's not as if there were new codes per se. It was just some waivers on the restriction of existing telehealth E&M services. And that highlights kind of a bit of a conundrum, which is that Medicare's value-based payment foray, which is now more than 10 years old, is still based on what's colloquially called the fee-for-service chassis. So generally, you've got the option and the incentive to reconfigure the services, maybe choose other services over more costly ones, but you're still constrained to using fee-for-service billing codes. And retooling generally may need to go beyond or outside the normal bounds of that fee-for-service chassis. But again, that brings us back to that whole issue of, are there PMPM payments? Is there some type of revenue cycle management? And again, I gave that example earlier of assisted telehealth, where maybe a paramedic would be critical to intercepting and reducing the severity of an emergent exacerbation of chronic disease. But even with unassisted telehealth, what if somebody just wants to check in on somebody, especially in this concept that Audrey mentioned of primary care being kind of the key instigator of population health. What if you just wanted to check on somebody, see them on video, kind of, if you know these patients, see what their mood is like. Maybe it's a Friday and you want to see how they're doing, hopefully get them through the weekend. Well, that might not be adequately problem focused to meet the standards of an E&M encounter. And again, building on a fee-for-service chassis, it's really just, consists mainly of restricted waivers that restrict waivers that remove restrictions, but you're still talking about the same codes. Is this problem focused? Is it complex? You could have the other side of the coin where maybe somebody is really in a flare and needs multiple telehealth encounters. What if you have the same patient receiving 3 to 5 telehealth encounters, all very complex and very problem focused? This idea that you build, for example, even progressive accountable care on top of the fee-for-service chassis is pretty restrictive. And so this idea of remote management and the benefits of telehealth, I think we really look to these ideas about primary care payment models. Now, at the federal level, there is one participant in our newest collaborative that's part of another Medicare payment model called Primary Care First. And that's directed a little bit more towards what we are all talking about, which is you have a primary care practice, responsible for the total cost of care. And rather than purely building reimbursement on the fee-for-service codes, the Primary Care First payment model actually includes some risk-based primary care population payments. So depending on the HCC scores of the primary care practice, and these tend to be much smaller practices than, say, an accountable care organization, but you actually get a risk-based population payment, which gives you much more of that flexibility. And you also can get reimbursed for the typical E&M services, but those are capped and discounted. So it's much more in the direction that I think all the panelists are talking about, which is more empowerment so that telehealth is not encumbered by the traditional E&M service codes, but is really something that enables that management of total cost of care and total population. And so we're also really interested in seeing how that's manifest in CalAIM. Here in California, that's such an important kind of revamp of the Medi-Cal payment model, and we're really looking forward to that. So I think that's the direction, is we need to be mindful that to see that risk is commensurately rewarded by opportunity, we really need to move not only towards total cost of care, but also unencumbering ourselves from the fee-for-service chassis because of the whole revenue cycle issue that everybody's been talking about.
Yeah, and maybe thinking too of as we unencumber ourselves from the fee-for-service chassis, and maybe even the brick and mortar one too. Thinking about what support providers need to move into the new value-based and kind of telehealth world. Maybe Audrey and Cindy, and Audrey, I'll start with you. What tools or resources is Blue Shield providing or thinking of providing when it comes to helping providers move into this new space?
Yeah, so we're definitely trying to work alongside of our provider partners, our clinical provider partners, and be sort of consultants to them to help them understand how to move into this space. one of the things that we've seen just across the entire state of California is that not everyone provides the same level of access to telehealth and or care. And so what we're trying to do is work with those who want to have a better telehealth virtual care strategy. How can we partner with them and then partner with other specifically maybe telehealth only groups to provide a bridge and make sure that there's enough telehealth access for our members. One of the things that might, and we're still sort of working through this, that might be applicable in this situation would be value-based payment. So that way we can just guarantee that revenue stream for those traditionally in-person providers. But that's one of the things that we're trying to do in an effort to promote primary care, not just being the foundation, but being able to be the foundation both in person and virtual.
Excellent. And Cindy, maybe can you elaborate on that a bit from the health center perspective? What are some of the tools or resources that might be deployed right now, or maybe that health centers might need in the coming years? With the shift in payment and with kind of telehealth here to stay.
Yeah, so excuse me. So right now, because we are right in the midst of negotiating with the state, we have developed what we are calling Cohort Zero. So this is a group of our members who are, raised their hand and said, I'm all in. I want an alternative payment model. I want to move to value-based care, even more so than we are now. And I want to be on the ground floor because I want to be in those discussions with you in the state about how this is going to work so I can understand what I need to do. So we have our Cohort Zero, and we are providing training and technical assistance around finance and operations, around care team redesign, and also around culture and change management, because those are three areas that when we did some surveying with our members that sort of were elevated as far as what they needed help with, right? So we're doing that. We started that last month, and we'll be doing that with the cohort through the end of this year. Then the state is going to be releasing a letter of intent, and we will work with our members to help them with that. They'll be releasing an application to go into the APM. Our members have said they're probably going to want some assistance with that. And in the meantime, we're always looking for and are continuing to develop learning modules. So we have a learning management system, and we have some training and resources that is sort of an on-demand library for those members who maybe need a payment reform, value-based care 101. They can go in and have their staff go through that. Covers all aspects of the basics. And then we've also done some work around creating, we've created a scheduling guide to help front office staff and clinics make decisions about the best type of care for patients. So do they need to be in person? Can it be a virtual visit? Does it need to be a video visit? Can it be a phone visit? So, we're developing tools and resources that they can use to train their staff to be successful in that type of an environment. We also have done some work around developing new workflows for virtual care. So, how do you do a primary care visit virtually? How do you do a warm handoff between primary care and behavioral health in a virtual world? So, we are looking at some of the struggles that we think they're going to have, and we're trying to develop tools and resources that will help mitigate and help bring them along. We really we have some consultants that we're working with that have done a lot of work around the financial aspects of an APM, and we're offering some consulting hours, one-on-one consulting hours for clinics that are in Cohort Zero to start to prepare. So it really is about all aspects of care and clinic life, and what's going to be different, and what do they need to be successful. So that's sort of what we're focusing on.
Excellent. It's great to hear about all the technical assistance CPCA is providing its members in this time. I think we can move to some audience Q&A, and I recommend folks, if questions come to mind, please feel free to drop them in the Q&A box. I think this first question I'm seeing here, I might pose to all of our panelists, depending on who would like to jump in, around how these changes account for patient privacy. For sensitive health issues like mental health. And it might add to the question too, how do you account for both patient privacy, but also how do you structure, a payment model that, may have patients with, severe mental illness or chronic conditions? What does that look like in the process of kind of developing a payment model and thinking about how to handle that data, and also how to, meet those patients' needs as well? Would anyone like to take that one?
So I can talk a little bit about the payment model. So actually, when you are doing a per member per month payment schedule, the idea is that you really want to manage that whole patient, right? So one of the key things to that is, this flexibility that's built into the payment model, and that you can do those warm handoffs and not have to worry about the fact that you can't bill for 2 visits in a day. So I'm at a conference, I was just at a session, and one of the behavioral health experts was saying that, from the point of a primary care doc passing a patient off for behavioral health, the longer period it takes for that patient to be seen in that second follow-up visit, the less likely they are to really get the care that they need and be helpful without them having maybe an emergency room visit or an urgent care visit or some other sort of intervention. So, telehealth and virtual and value-based care eliminates that, because if a patient comes in for primary care and is evaluated and needs to have a behavioral health visit, you can make that handoff right then. A lot of our clinics do that, even though they can't bill for it, but it makes it such a much easier process, and financially does not impact the clinic. So there's a lot of pluses to being able to do that kind of work, much more patient-centered. And, in the long run, I don't know that we anticipate that primary care visits or behavioral health visits are going to go down from a clinic perspective, because if we're doing our job up front better and seeing patients they need to be seen, then we're keeping them out of those more high cost environments. They're not going to the hospital. They're not going to the emergency room. They're staying in the environment where they feel safe, which is their home. And behavioral health patients love telephone visits. I mean, from all the feedback that we've gotten and the surveys that we've seen, they like behavioral health visits because, Robbie, if somebody walks into their home while they're doing that visit and they're on the phone, they can just walk outside or walk into another room and get that privacy that they want and need. So everything that we've heard from our members and our patients is that they, from a privacy perspective, they like to be able to do the phone visits if it's appropriate, because they can continue to make sure that they have that privacy that they need to do the visit and have those conversations. So I'll stop and let my other colleagues respond, because I see everybody shaking their head.
Yeah, I'll just add to what Cindy was saying. Things like the collaborative care model, where primary care providers are the first ones to be able to identify behavioral or mental health concerns or issues, and then work sort of asynchronously with a psychiatrist to perform medication management, to make sure they're monitoring the PHQ-9 scores, and then also provide the sort of continuous outreach through health coaches and through behavioral health specialists. I think all of that is enabled. Being able to do that can happen through value-based payments, because some of these interactions maybe potentially that are not billable now providers and their care teams can still do them while still guaranteeing this revenue stream coming in.
And Robbie, I was just going to comment on an observation that we've kind of gleaned from our collaboratives, which is that the payment models almost universally will be risk adjusted. So somebody that's got maybe serious behavioral health challenges, that will be reflected in the risk adjusted payment. I think one of the pitfalls that we become aware of is that even within a similar group of risk-adjusted patients, the utilization in a traditional insurance-based program is very heterogeneous. And that's the nature of insurance risk, is that you, if, for example, Medicare pays a Medicaid program, I'm sorry, if Medicare pays a Medicare Advantage program, the PMPMs tend to be risk adjusted, but I think the cautionary tale is that the utilization tends to be very heterogeneous. So providers need to be careful that they don't just assume that the PMPM for an individual beneficiary reflects the actual utilization. It tends to be a whole bunch of people use and need less, and then a few sprinkling need a whole lot more. So although I think we're all on the same page and espousing the idea of PMPM, there are some cautionary tales that when risk moves from insurance companies to providers, that heterogeneity doesn't go away. And I think there's some providers that run the risk of just taking the PMPM and proportionately doling out services, only to find that some outlier that insurance was intended to cover ends up needing a lot more than those PMPMs will cover. So I think we have to be careful of those pitfalls, that risk is a very complicated game, and pushing risk over to providers may have some unintended consequences.
And one last question, I know we're coming up on time, but for each of you, maybe really briefly, what would you say to someone who's dragging their feet? I saw Mike's question come in, and someone who may be dragging their feet in terms of transitioning to value-based care or value-based payment. If maybe each of you could share some words of wisdom.
I think the words of wisdom that I would have is let's talk, right? Like, let's try to figure out how we can make this work. We do recognize that not one size fits all, just like in traditional care delivery, right? Not one size fits all. So there is going to be a way that we can come together and even experiment until it's proven to be successful for all organizations that are involved in value-based payment. So that would be my one thing, is let's just talk.
I think I would only add that it's remarkably bipartisan in this polarized political climate. It seems that every administration is committed to value-based care. That's an extraordinary outlier.
Yeah, and I mean, what we say to our members is that it's coming. So what can we do to help you get ready for it? We have a needs assessment that we suggest that they do to look at their readiness for value-based care, sort of what they're doing, where they need to go, and sort of how can they take small bites out of the apple to get where they ultimately need to be, so that it's not so overwhelming. And we also suggest that they try to integrate it into work they're already doing. So if you already have some sort of initiative going on, don't go to your staff and say, oh, now we're going to do value-based care. Slowly integrate it into what you're already doing, because it overlaps and links with so many different things. And that is a much easier message for staff who are, especially over the last 2 years, overwhelmed and under-resourced. Instead of piling on something new, say, we're going to improve this process that we're currently doing, and make it part of what you're already doing, and don't segregate it and make it something special. It's really what you want to be doing anyway. So
Well, thank you. I think that's the same message we always send around telehealth too, that virtual care is care. I just want to thank, Cindy, Chris, and Audrey so much for your time today and for the great discussion and all of your time spent on prep. And in May, I'll hand it back over to you.
Thank you, Robbie. And also thank you to you for your wonderful moderation today. Once again, we want to thank our panelists, Chris Crowley from West Health, Cindy Keltner from the California Primary Care Association, Audrey Young from Blue Shield of California for taking time off to share their insights on value-based care with us today and how it relates to telehealth. Thank you once more to Robbie Francescini from Blue Path Health for his excellent moderation. Thank you also to our attendees for being here today and staying with us through the entire webinar here. You will receive an evaluation form once this webinar ends. So if you could fill that out, that would really help us out. We would also like to thank the sponsors of this webinar, the California Healthcare Foundation and Center for Connected Health Policy. If you have questions regarding the coalition or this webinar today, please feel free to reach out to CCHP staff. We'll be happy to answer your questions. Other than that, thank you once again to our panelists in our webinar. Thank you to all of our attendees. Thank you to our sponsors. Have a great day and have a happy 4th of July.
Thank you.
Thank you.